Hello, Partnering for Vaccine Equity learning community members and others working to advance vaccine equity. My name is Jenny Haley. I'm part of the group learning team for the learning community, and on behalf of our team at the Urban Institute and our partners at the CDC, thank you so much for being with us this afternoon, or maybe morning for some of you. So we're entering a new phase of the COVID-19 pandemic as of May 11th, 2023, which is just next week. The federally declared public health emergency, sometimes called the PHE, will expire. And we're hearing from many in the learning community that you're wondering how this will affect your vaccine programming. And so this learning session was designed to give you answers to some of those questions. So first, we will be joined by the CDC's Sarah Meyer to discuss what's changing in vaccine access and as well as what isn't immediately changing. Then we will turn to the CDC's Benita Harris, who will provide a brief overview of a program called Vaccines for Adults, which has been proposed in President Biden's budget. And these presentations will be followed by breakout sessions where all of the attendees can meet in a smaller group and talk about strategies for how you'll be communicating about vaccination access following the end of the PHE and how your plans for advancing vaccine equity might be changing, evolving as the nation enters this new phase of the pandemic. Just a quick plug to let you know that the PAVE learning community hosted a webinar on just a couple weeks ago on April 19th, which was focused on changes to Medicaid enrollment policies around expiration of Medicaid coverage protections that were enacted during the PHE. And so we encourage you, if you weren't able to attend that event, to check out that recording. It might answer any questions that you might have specifically about the Medicaid coverage changes that are occurring right now. Before I hand things over to our speakers, I'll review a few key points about how this session will work. First, we offer live interpretation from English to Spanish during our events. If you would like to listen to the Spanish language channel, simply click on the icon, it looks like a globe on the your Zoom taskbar, and that should be at the bottom of your screen. You've all been muted upon entry to the session. If you have a question for our speakers during the presentations, we ask that you use the Q&A tool in your Zoom taskbar to submit the question. We have also dedicated some time for questions at the end, and you can also ask your question live if you'd like. You can use the raise hand feature and we can take you off mute so you can speak. The chat room feature is also open today, and we encourage you to introduce yourself or to comment on what you're hearing. Please try not to put your questions for the speakers and panelists in the chat because we might miss them there. You can submit them to the Q&A instead. If you have any technical difficulties at any point during the session, send an email to our community manager's inbox, which is vaxequitylearning@urban.org, so that we can assist with troubleshooting. And as with all of our learning events, we will post the slides and a recording of this event on our community website and circulate them through the digests that go out through part of the CDC managed adult vax program listserv, which all PAVE program members should be a part of. And finally, as I mentioned, when our featured speakers have been finished presenting, we will hold breakout sessions where attendees can talk in a smaller setting. And when it's time to go to the breakout rooms, you'll be automatically assigned to one. So you don't need to do anything at that time. Then you'll automatically come back to the main room for discussion and Q&A with our speakers at the end. I would like to let you know we are very fortunate that 3 learning community members, Mary Catherine Jones, Lachelle Pugh, and Carol Lemus, as well as the Director of Group Learning here at the Urban Institute, Bridget Corto, have agreed to serve as facilitators for those breakout sessions and help lead these smaller group discussions. So thank you in advance to our facilitators. So now it's my pleasure to introduce today's featured speakers. Dr. Sarah Meyer serves as the Chief Medical Officer in the Immunization Services Division, or ISD, at the Centers for Disease Control and Prevention. Dr. Meyer is a board-certified pediatrician who completed residency at Boston Children's Hospital and Boston Medical Center, as well as an applied epidemiology fellowship through CDC's Epidemic Intelligence Service. She has worked both domestically and globally on vaccine preventable diseases and vaccines, and has held numerous leadership roles in CDC's COVID-19 vaccine task force. In her current role as CMO in the Immunization Services Division, she coordinates cross-cutting work related to the COVID-19 vaccination program, strengthening routine immunization catch-up, vaccine confidence and demand, and preparedness and response activities. Benita Harris is a community engagement and vaccine equity subject matter expert, also in the Immunization Services Division. She serves as the team lead for the Learning Community and Partnership team in the Partnerships and Health Equity branch, where she leads efforts to provide technical support to funded community partners through a learning community and to combat vaccine misinformation and disinformation. As part of the PAVE program. And prior to that, she was deputy at NSME for the racial and ethnic public health issues for the adult population team on the COVID-19 vaccine task force and has had a long tenure at CDC. So we are really grateful for you both, Sarah and Benita, for being here today and sharing your extensive expertise with us. So Sarah, I will turn the floor over to you.
Great. Thank you so much for having me here today. As Jenny mentioned, I will be talking about COVID-19 vaccines and the end of the public health emergency and what that means and what that doesn't mean for vaccines, and also give a look ahead of what we can also expect over the next couple of months. Next slide. So I wanted to start first with just kind of reviewing what the overarching objectives for the U.S. COVID-19 vaccination program are. These were objectives that were laid out at the beginning of the COVID-19 response, and that's to ensure the safety and effectiveness of COVID-19 vaccines, reduce mortality, morbidity, and evidence and incidence of COVID-19 disease, help minimize disruption to society and the economy, including maintaining healthcare capacity and ensuring equity in vaccine allocation and distribution. And I just wanted to highlight that, now several years into our COVID-19 vaccination program, these remain the objectives of our program, and the public health emergency doesn't change, that these remain the overarching objectives of our program. Next slide. So as just mentioned, we have the same goals of our program, but we will have some changes in how the program, how the program is working. So first I'll start with what will change. And what will change, primarily the main change we will see when the public health emergency ends on May 11th is some changes in how our data are reported and displayed for use. So we will have possible reduced submission of vaccine administration data from some jurisdictions, which may limit the completeness of administration data on a national level. Most jurisdictions have signed a COVID-19 vaccine data use agreement extension through the end of 2023. So we do still expect to have data, but the completeness of this data may change. We may need to rely a little bit more on some of our surveys rather than the actual numbers of people who have gotten, administered in our immunization information systems. But this is really the main change that we'll see is kind of on how much data is collected and how it's reported and how we communicate that to the public. Next slide. So now I'll review what will not change. And just to kind of cut to the chase, most things will not change at all after the PHE ends on May 11th of this year. We are continuing to work with public and private partners to learn more about the short-term and long-term effects associated with COVID-19, who is affected and why, which will help us to implement vaccine recommendations to optimize protection. the public health emergency ending does not change anything related to FDA's emergency use authorizations for COVID-19 products, including vaccines. The products that are under emergency use authorization will continue. We will continue to be able to use that mechanism to have vaccine products available and recommended. And importantly, all vaccines purchased by the US government will continue to be distributed and available for free. So I want to clear up probably the biggest misunderstanding that we've been hearing, and that the public health emergency is not the same thing as commercialization of the vaccine. So before I kind of move into talking about what does that mean, commercialization, just to kind of reiterate, most things are not going to change at all after the public health emergency ends as it relates to the vaccination program. The main changes will relate to data, but vaccines will continue to be provided, distributed for free as they have been for the last couple of years. Next slide. So then what is commercialization? So commercialization of COVID-19 vaccines is the transition of vaccines previously purchased by the US government to the more established pathways of procurement, distribution, and payment by both public and private payers. So this will be very similar to how flu vaccines, for example, are provided, and essentially of all of our other routine vaccines. This is kind of moving towards the more traditional system for vaccines. So in terms of the timeline, this will likely occur in early fall. So we have several months to continue to prepare for this. And the exact timeline, we don't have like a date on which this will happen. Unlike for the PHE, we know exactly what date that will happen. We generally just know that this will happen in the fall, and this will likely coincide with when we might have new authorizations by FDA and recommendations by CDC, and the alignment with the strain change for potential variants. So essentially in the fall, if we have a new updated COVID-19 vaccine, that is most likely going to be the trigger for when the product will become commercialized, because all of our existing vaccines that were distributed by the US government would no longer be recommended for use, and the new updated vaccine would be with what we would be going with from that point forward. And that's when more traditional payer pathways would need to kick in. But just to emphasize that after commercializations, vaccines will remain free for most people through the Vaccines for Children program, Children's Health Insurance Program, most commercial insurance, as well as Medicare and Medicaid programs. Next slide. But COVID-19 commercialization will mean that some people lose access. So when COVID-19 vaccines and therapeutics are moved to a commercial market in the fall, about 25 million uninsured adults will lose access. And this figure, this kind of pie chart, just kind of shows, the distribution of the adult population by their coverage status. So a little less than a quarter of people are considered uninsured. The largest proportion so the uninsured is in the yellow. Our privately insured population is in the dark blue, Medicare in kind of that grayish light blue, Medicaid in the royal or the bright blue, underinsured in the dark blue, and then uninsured in the yellow. So it is a significant proportion of our population is uninsured. The permanent solution to this, which Benito will talk about, is the proposed Vaccines for Adults, or VFA program. This would be the permanent solution to the problem. But as mentioned, what we, for that to happen, that would need to be authorized and funded by Congress. So we don't exactly know if or when that would happen. So we do need a temporary solution in the interim to ensure that we maintain coverage for COVID-19 vaccines for uninsured adults. Next slide. So this leads us to the Bridge Access Program, which is the program designed to do just that, to provide a bridge for our uninsured adults from the time so that they don't go from having full access to COVID-19 vaccines to difficulty paying or difficulty affording that. So HHS and CDC have been working to ensure broad access to vaccines and therapeutics once these products are commercialized, including for the uninsured. And so there had been some planning to fund programs for the uninsured through local health departments and the Health Resources and Service Administration, or HRSA, supported health centers. But so that had been kind of the original plan, but there is now also another component related to pharmacies and pharmacy-based programs. And this was due to the recognition that pharmacies have played a significant role in providing COVID-19 vaccines to the adult population. So this past fall season, over 2/3 of vaccines were administered in a pharmacy. And most adults live within 5 miles of a pharmacy. So essentially, we have kind of a joint program now that was announced on April 18th called the HHS Bridge Access Program for COVID-19 vaccines and treatments, which is designed to maintain broad access to COVID-19 vaccines for millions of uninsured Americans. So this program creates a unique $1.1 billion public-private partnership to help maintain uninsured individuals' access to COVID-19 care. And again, it includes kind of 2 components. Delivery of vaccine doses through local health departments and HRSA-supported health centers, and secondly, to deliver additional vaccine doses as well as selected therapeutics through a novel funded partnership with pharmacy chains. Next slide. So I'll walk through a few of the components and just keep this figure in mind as Benita talks through the Vaccines for Adults program, because what we're really trying to demonstrate is that this program is a bridge to a more permanent solution. So some of the components have some areas of overlap, but there are some, there are some differences as well. So for the Bridge Access Program, there will be limited purchase of COVID-19 vaccines. This includes a one-time allocation for purchase of a limited number of COVID-19 vaccines for uninsured adults. And this is really meant to also leverage and complement the manufacturer's kind of commitments to providing vaccines through a patient access program. These efforts are meant to harmonize so that we are working together with manufacturers to ensure access, as we have, all of us have committed to that. There will also be a limited funding for program operations in the form of a one-time limited allocation for CDC staff and systems to support science, policy, program monitoring, and vaccine safety and distribution. Also, provider fees for limited groups of providers, including allocation for limited providers reached through existing government contracts to cover supplies, patient education, storage, staffing, and vaccine confidence and equity activities. In terms of the vaccine confidence and equity activities, a requirement for health departments and centers and pharmacies to develop community partnerships and outreach. This is kind of baked into the program. For example, pharmacies being, as part of this program, doing that community outreach and things like that. In that kind of pink bullet, you see this kind of provider fee reimbursement mechanism. This is not currently part of the Bridge Access Program in terms of provider reimbursement mechanisms. The reason why it's on this figure is because we will talk about that when we get to talking more about VFA and what that provides and some of the distinctions we're trying to make with the program, but that is not currently authorized under the Bridge Access Program. Next slide. So that kind of summarized the Bridge program, which would help for uninsured adults, but there are also some other recent updates that will help ensure more broad access, notably to our Medicaid and Medicare eligible populations. So the Inflation Reduction Act is also a really important and exciting development in the adult immunization space. The Inflation Reduction Act was passed in August of 2022 and includes several key provisions, which will eliminate cost sharing for all ACIP recommended vaccinations under Medicaid and Medicare Part D equivalent plans. That has already started in January of 2023, and also guarantees that nearly 50 million Medicare beneficiaries and more than 80 million Medicaid beneficiaries will have access to all vaccines recommended by the ACIP without cost sharing. So this is really remarkable because in the past, there may have been some out-of-pocket costs for some vaccines. There might have been, things might not have always necessarily been fully aligned with the ACIP recommendations in terms of who can get covered for what vaccines. So now, as long as a vaccine is covered or recommended by ACIP, people who have Medicaid and Medicare will not incur any out-of-pocket costs. So we hope that this will also really remove barriers, including to some of the more expensive vaccines, like zoster vaccine, for example. But this also does apply to COVID-19 vaccines. Next slide. So looking ahead, I've kind of summarized some of the recent updates in ensuring access to vaccines as we move through this period over the next couple of months of transition, but also just wanted to close with kind of where we think we're going overall. So we're continuing to communicate about the public health emergency ending to various partners and groups, collaborating with our partners on vaccine commercialization, because that will be the next big milestone in our COVID response overall. We're maintaining a continued focus on vaccine equity, also our commitment to increasing vaccine confidence, but also, more just generally our continued surveillance of the viruses so that we can be prepared from a vaccine standpoint to meet any of those challenges that may come up, and continuing our efforts to understand how well the vaccine is working, which will, as we move through the different variants and different updated vaccines, so that we can continue to provide that information to encourage people to continue to go out and get their updated shots as we move into the fall. I think that's it for me, so I'll close there.
Thank you so much, Sarah. A number of great questions are coming in, but just one quick clarification. Has it been announced when the LHDs and health centers that will be supported under the Bridge program will be named?
No, and I would say that there are still a lot of details being, this program hasn't been implemented yet. Again, we're looking towards the fall for implementation. So I think the main idea would be that we would work through our immunization awardees, state and local, tribal, territorial health departments, through our existing mechanisms, such as the 317 program, to leverage those existing systems to ensure access to, at health departments, federal FHQCs, things like that. So I think a lot of those decisions would be made at the state level, awardee level, but the program has not been implemented yet.
Thank you so much. And now I will turn things over to our next speaker, Benita Harris. Thank you so much.
Thank you, Jenny. And I'm going to sneak off camera while I present to give us a little bit more bandwidth, and so that you all can take in everything that we're saying, so that we will have a robust discussion. So in advance, thank you. In the previous presentation, Dr. Sarah Meyer provided an overview of the temporary HHS Bridge Access Program for COVID-19 vaccines and treatment. This program is a two-part bridge program that is in place to maintain access to COVID-19 vaccines and therapeutics for under and uninsured adults for the first year after commercialization. The first component of the bridge program, as you heard, runs through the existing public health infrastructure Retail pharmacies support the second component. The Bridge program will provide access to COVID vaccines and therapeutics under and uninsured adults who do not have insurance, and most Americans with insurance coverage will continue to pay nothing out of pocket. But please keep in mind that the Bridge program is temporary and only maintain access to COVID-19 vaccines and therapeutics for under and uninsured adults for the first year after commercialization. However, the proposed Vaccine for Adults program, which you can find an overview of in the 2024 presidential budget request, serves as a more comprehensive, long-term solution that will support vaccine equity through partnerships, communications, and technical assistance. So with that, let me tell you a little bit more about the proposed Vaccine for Adults program. Next slide, please. Adult vaccine rates in the United States, as we know, have been far below the optimal levels to prevent and the spread of disease, and are lower for those experiencing health or socioeconomic disparities. The lack of equitable access to recommended adult vaccination is a significant gap in our public health infrastructure. And so the proposed Vaccine for Adult program will address that. Next slide, please. The lack of health insurance coverage is also a significant factor in under-vaccination among adults. A significant percentage, a little more than 10% of adult populations under age 65 is uninsured. Among adults impacted by high costs, 56% never get vaccinated. And during 2017-18 season, for example, only 16.2% of adults without health insurance received the influenza vaccine. So the lack of insurance for many adults have created inequities to access and vaccination and inconsistent outreach and engagement from health systems. So cost is also an important barrier to vaccination for a large portion of our populations in the US. Next slide. COVID-19 has revealed to us that many adults lack confidence in vaccine and in government, and highlight the need for a robust adult immunization program. To address these issues, CDC seeks to establish an equitable, sustainable vaccine for adult program. This program will reduce the spread of preventable diseases by providing uninsured adults access to all recommended routine and outbreak vaccines at no cost and supporting high vaccination rates for all uninsured adults. This program would include new mandatory funding for purchase of vaccines recommended for adults, including routine vaccines, COVID-19, and vaccine to control outbreaks. It will also provide reimbursement for provider fees at a fixed rate, and the program operations will be included to establish contracts to administer the provider reimbursement process as well. CDC will also work with jurisdictions to leverage base immunization funding and other resources associated with program operations costs, vaccine confidence, vaccine equity activities, including communications, partnerships, education, and technical assistance. Next slide. However, these barriers to vaccination are not unique to COVID-19 pandemic and leave many adults vulnerable to vaccine preventable diseases. These are long-standing categories of barriers to vaccine uptake. Accessibility is when there's a lack of health insurance, which makes vaccines unaffordable. There's also availability, where there's a lack of availability of supply of vaccine and lack of providers who are distributing vaccines to eligible adults. We all are aware of the issues around confidence. There's a history of disparities and discriminatory patterns, and there's a rise in mis and disinformation about vaccines. Next slide, please. These barriers related to vaccine availability, access, and confidence impact real people. These are some examples of how they impact real people. Sam is 20 and lives in a highly rural area. He doesn't live close to a pharmacy or a clinic, so that limits his access to vaccine. Marta, 59, wants to get vaccinated at a local pharmacy. And when she goes to the pharmacy, they've run out. So the proposed program will make vaccines available. And Rohan is 44 and isn't sure if he wants to get vaccinated. So the programs that we have with many of our partners ensure that they are trusted messengers from trusted places by trusted people so that Rohan will feel comfortable about receiving vaccines. Next slide, please. Immunization programs and funding for children are far more robust than they are for adults, as you can see from this slide. The Vaccine for Children program also addressed ACIP recommended schedules in terms of coverage of vaccination, in terms of support at the state and public health infrastructure, and all states offer immunization information systems for our children for vaccines. You can see that when it comes to adult vaccinations, there are limitations when it comes to those who are uninsured, underinsured, uninsured, and even it varies at the state and public health level, as well as with immunization systems. And so the Partnering for Vaccine Equity program will stand to address these information by assuring that access, availability, and confidence are in place for our adult populations. Next slide, please. In response to these challenges, CDC deployed billions in COVID response funding to hundreds of national, state, local, and community partners. Many of you are familiar with our Partnering for Vaccine Equity program. That program is in place to increase vaccine equity and uptake in racial and ethnic minority communities. We've been able to fund over 60 primary partners, who in turn have supported over 500 subrecipients. Our Vaccine Confidence and Demand program builds vaccine confidence and generate demand. We've been able to support over 20 primary partners, nearly 200 subrecipients. Our Disproportionately Adult Affected Populations program has supported over 45 primary partners and nearly 700 subrecipients to address adult populations who are disproportionately impacted by COVID-19. And of course, we have supported our state, territorial, local, and tribal immunization programs by providing equitable support for COVID vaccine access and expansion of partnerships with communities to over 64 primary partners at the state, territorial, local, and tribal levels. Next slide, please. As you can see from this slide, there's recent data that suggests that the efforts of this partner network has contributed to reducing racial and ethnic disparities in COVID-19 vaccine rates. So that shows us that within the short span of the operations of our program, our actions and efforts have been very instrumentally important and have been able to demonstrate the interventions and activities and tools that we've used to show that we have been able to reduce some of these disparities. And this program has paved the way to what is being proposed in the Partnering and the Vaccine for Adult program. Next slide, please. The rapid COVID-19 vaccination rollout and collective efforts of CDC and all our partners saved many lives. Many of you can attest to that. This slide shows that even at our heightened efforts, when we were trying to address the 2021 spring surge with nearly 4,500 deaths per day, the efforts of our program from Partnering for Vaccine Equity and many of our other health equity vaccine programs were able to show that our efforts have had significant impact. Next slide, please. These efforts and investments have created the momentum toward a comprehensive adult immunization program that we're calling Vaccine for Adults. CDC has invested $10 billion to expand access to and confidence in COVID-19 vaccinations in highest risk communities. The programs have provided free COVID-19 vaccines for all. We've been able to establish new partnerships with pharmacies across the US, and there's funding and support that has been deployed to hundreds of partners to address racial and ethnic disparities. Next slide, please. However, significant additional investments will be required to sustain these efforts. As you can see from this slide, the future of this work depends effectively on addressing several challenges. We need to be able to sustain the progress we have in reducing immunization disparities and building new partnerships. We need a more permanent solution that doesn't rely on emergency dollars and COVID-specific authorities. And we also need to work more at addressing the risk of long-term declines in routine immunization in children as well as adults. Next slide. Vaccines for Children provided that framework, and our Partnering for Vaccine and other vaccine equity programs have been able to demonstrate that a vaccine for adult program, which is proposed in the FY24 budget, will be the robust program that is much needed to sustain the efforts that we put forward. VFC has helped promote integration of immunization for routine child and adolescent healthcare. VFC has also been able to prevent approximately 419 million illnesses and has saved us nearly 1.9 trillion in social causes. The program has also increased vaccination rates across all races, ethnicity, and income groups. So what we've seen from the VFC program and the path that has been built by our Partnering for Vaccine Equity program, as well as our many other vaccine equity programs during the pandemic, shows that there is a need for a vaccine for adults program, and VFC has set the model and stage for that. And so having that program in place will serve as a safety net to ensure that all can be vaccinated. Next slide, please. You saw this slide a little earlier when Sarah talked about it, but you see it's a little different. The proposed Vaccine for Adults program will reduce the spread of vaccine preventable diseases, and as I stated, pave the way to greater health equity. Through this proposed program, there will be vaccine purchases for all recommended vaccines for all uninsured adults. There will be support for program operations. There will be support for provider fees and provider fee reimbursement mechanisms in place, such as contracts to administer provider reimbursement process. Vaccine confidence and equity activities, many of which we are implementing now, will be in place to support vaccine equity through partnerships, communications, and technical assistance. Next slide, please. VFA would cover the 14 ACIP recommended adult vaccines and any additional ones to the list over time with no cost sharing. Next, please. CDC has proposed significant new mandatory funding for this VFA program. CDC's FY24 request of $12 billion in mandatory funding for VFA over 10 years will expand access to all routine and outbreak vaccines to uninsured adults. These funds will be used for vaccine purchases, provider fees, provider fee reimbursement mechanisms, and program operations. Next slide. The proposed vaccine for adults will be a major step toward addressing key barriers in terms of accessibility, availability, and confidence. Next slide, please. The vaccine program will give uninsured adults meaningful access for the first time. Those who live in rural areas will have access, whether it's through a local clinic, a mobile pop-up, or the local church. Local pharmacies will now have adequate vaccine to distribute, as you heard from our Bridge program. Vaccines will be free at corner pharmacies, and Rohan, just as others who have been skeptical about vaccines, but trust those who deliver, will be able to receive vaccines and information about vaccines from trusted people and trusted places. Next slide, please. You saw this slide earlier, and I think Sarah kind of talked to this about the coverage that we have. So just to add a little bit more there, VFA would cover the cost of vaccines only for uninsured. Other existing programs or proposed programs, including ACA compliant private insurance, covers many other. And the current Section 317, as you saw with the Bridge program, immunization funds are insufficient to cover those without or incomplete vaccination coverage. Next slide. This slide shows where those significant gaps exist. Now, Sarah talked a little bit about the Inflammation Reduction Act of 2022, so I won't say much about that. She also touched on Medicare Part B as a part of that Inflammation Reduction Act. And we also talk about short-term limitation, duration insurance, and non-ACA. And of course, there are some limitations with children whose health insurance coverage vaccinations are not eligible under VFC, even when subject to cost sharing. Next slide. So the VFA would complement other proposals in the FY24 budget that also extend critical access to vaccination. So together with VFA, this will allow us to reduce disparities in vaccination coverage, improve control of vaccine preventable diseases, and enhance and maintain infrastructure for responding for future pandemics. So in addition to the request for VFA, there is also a request for funding to expand the VFC program to all children under age 19 enrolled in TRIP. And we also are asking for an increased investment in CDC's discretionary Section 317 immunization program. Next slide. VFA is one critical step on the path to complete vaccination coverage. Each of these steps are needed to complete the vaccine safety net and ensure equitable access to vaccine. So the proposed VFA program, as well as the enhancements to VFC coverage and the request to increase 317, along with the many other programs that are currently in place, will lead us toward the path, toward the final piece to complete the safety net for vaccine coverage. Next slide. That concludes my overview of VFA. And as stated, we'll be breaking out into some breakout sessions. If you have any additional questions, please include them in the chat. And we're looking forward to a robust discussion during our breakout sessions. Thank you.
Thank you so much. So we're going to propose a slight change of agenda here. There's just so many good questions coming in, and we'd like to take advantage of the expertise of our CDC representatives. So what we're going to do is hold on those, and we'll be in touch with a special session where you can talk in small groups. And we hope that some of the amazing facilitators who agreed to join us will be willing to come back on that day. We just have so many good questions. So I did want to say that we're going to also collect all of the questions that we don't have time to get to today, and we will get some answers to those and be sure to share them with you with the other presentation materials. And one question was about community-facing resources about this information. And I just wanted to note that I shared a link in the chat to a resource that's a one-pager that distills a couple of these questions down. So let's start with a couple of quick questions about the VFA program, since you just presented on that, Benita. Thank you. What's your sense of the likelihood that it'll be improved? And you're on mute.
Sorry about that. Yes, as stated, that is what CDC has proposed. Through the programs and the efforts of our PAVE program and the work of our other vaccine equity partners, that what we've done through Partnering for Vaccine Equity has been able to demonstrate it has actually paved the way to what is needed, that safety net, which is VFA. As with most federal agency, it is proposed in the budget and will require a congressional vote in October, early October, to secure those fundings. As stated by Sarah earlier, the emergency fundings that we have now, which is used to support many of those programs, will go away on May 11th with the end of the public health emergency. So the likelihood is something that I cannot say. I know that we have been sharing the information about VFA. We hope that our partners are hearing this information and that our partners are sharing this information and are also stressing the importance of this to continue so that it will land upon the ears of the appropriate person and decision makers to ensure that VFA is funded.
So any specific guidance for how PAVE grantees can encourage their community partners to help advocate for this?
I know recently we conducted in the learning community a legislative awareness session that engaged partners on how to talk to or engage with legislative bodies and of their community to talk about not only what is needed, but also to talk about the success that they've had with the dollars that have been appropriated that put the PAVE program and other efforts in place. So continued conversation like those at the community level and with partners. I think that session is recorded. It might still be up, Bridget. They can take a look at that. And Urban Institute has been one of our technical assistance partners who has been providing support to our partners one-on-one and even in sessions like that to sort of help gauge them through the process. So I would suggest town halls, community forums, sharing the success of your program so far, talking about why this is important and the need for it to continue.
And I
Thank you.
did, yeah, I offered that we will send out the links just for easy access to the sessions we've done on legislative advocacy with the materials to all the registrants that we send after the fact. And I'm not sure if there's any sort of community facing one page or anything on the VFA, but we will look and see what we might be able to share in terms of something that you could easily share with people that kind of explains the program. We'll work with Benita to see if anything exists that could be very easily kind of handed out or that would explain it on a piece of paper.
And if not, Bridget, we can put something together. I appreciate you. Thank you.
Okay.
Thanks, Bridget. Then we have a number of questions about the Bridge Access Program. So, Sarah, could you clarify about provider fee reimbursements, administrative fees, how some of these fees would work?
Yeah, and I will say, this program was just announced. I'm not sure if even all of the details are worked out. I mean, we can refer people to the fact sheet, which is published. But, in terms of, the, health department and HRSA funded clinics, I think we are anticipating that working very similar to how 317 vaccines are provided through public health means, which is less relevant to the reimbursement for administration fees and things like that. So I'm assuming this is kind of focused on the pharmacy aspect of it. And what we do know is that what has been proposed are kind of per dose payments to the pharmacies to cover all of the necessary costs related to administration and things like that. So there are payments being proposed to the pharmacies to help cover some of their fees, but we're not, to my knowledge, talking about kind of traditional reimbursement type pathways. This is kind of a public-private partnership program, so it's more of a providing payments to kind of cover some of their costs.
Thank you. And there's a question about the number of purchased vaccines. Is that something that's being disclosed? Any sort of projection about how long the purchased vaccines will last?
I do not have that information. I don't think there's anything on any of the public facing about number of doses that we're talking about. I would say, I'm based on my knowledge of the program, there has been a lot of attention paid to making sure that we can cover the uninsured population who wishes to get the vaccine. So I don't know the number of doses, but I think we can feel confident that if there's an uninsured person that wants to get a vaccine, that hopefully through this program, that would be an option for them.
And is the one-time funding for the Bridge program assured? Does it need to be approved? Is this definitely happening? And could it be renewed?
Well, it is happening. So that has kind of some of the inner workings that are necessary to fund such a program have those steps have been completed. So I think we feel very comfortable that this program will happen. HHS has announced it, and there, like I said, I think over the next couple of months, there will be work to operationalize it. So I don't think we have all the answers today on how this will work or all of the components. But I think over time, we will have more of that information to share. But just to say, I think it's happening. So I think people can feel confident in that.
Thank you. So there are a number of questions about COVID testing, and I know that's not specifically what we were planning to talk about today, but if either of you have any thoughts to share, resources on impacts on COVID testing, not specifically at-home tests, but at clinics or pharmacies.
There are, I can share, Jenny, with you. We have some talking point or information summaries that talk about things other than vaccines. I'm happy to share that with you, and that can absolutely be distributed out. I know I am not an expert on all things testing, or, and I'm not sure about Benita, but I think we can probably provide more of the vaccine angle, but can share some written information on the other components to be shared.
And we can get together on that, Sarah, because I'm certain that if you're talking about treatment for COVID, you're gonna have to be diagnosed before you treat it. So I'm certain that testing will be in place, and it will be opportunities to ensure accurate testing for determination of a diagnosis. So I'm certain that will be in place. And I think someone mentioned, will the bridge be renewed? We're hoping that the proposed vaccine for adult program is approved so that we will have that smooth transition from the bridge, which is to bridge into VFA. And I know it may take a moment to go through the transition of getting the VFA program up and running, if it is approved. And if that's the case, I'm assuming that it may be, if it is necessary to continue or extend some of the efforts of the bridge program, then that may happen, because we definitely do not want to have any gaps in those rates or gaps in services. Thank you.
Thank you. So there's another question on, this is a little bit of a more big picture question. What happens if there's a new variant or cases really rise? What will happen then in terms of the PHE and some of these programs?
Well, I think, when decisions around the PHE ending were made, I think there was taken into account that there are potentially scenarios in which we would see a new variant. But I think we are in the phase of the pandemic where things have changed. There's available vaccines, there's therapeutics. Most people have some form of immunity, whether that's vaccine induced, infection induced, or a combination of both. So I think we are in a little bit of a different phase of the pandemic where we do have more vaccine and therapy, options to prevent and treat if we did. So I think this signifies a transition to a little bit more of a like traditional ways of dealing with pathogens, similar with flu, how we do our flu vaccines every year. There could be bad flu seasons, mild flu seasons, but we have that capability to scale up in terms of our vaccination efforts, our communication efforts, our therapeutic efforts. We have built more infrastructure and capacity at all levels to kind of deal with these threats. So, we're not the people that can say, if a PHE would ever be declared again. But I think a lot of these factors have been taken into account on when to conclude the current PHE.
And Sarah, I add a little bit more to that. Don't know how many of you have taken the opportunity to take a look at the proposed FY24 budget. Given everything that we have learned in the pandemic, there have been key changes and recommendations proposed in that budget. There has been, I think, $600 million, which represent a $250 million increase from FY23 for public health infrastructure. There's funding to address a strong and more robust pandemic preparedness effort to address a lot of those things. There are also additional funding for organizations such as ASPR, CDC, NIH, and others, and those things are clearly spelled out in the budget. And again, as always, and as a reminder, Congress has the authority to approve, reject, or modify the administration's budget recommendations. So that's why it's important that we are aware of what is requested and that we understand clearly what is needed to continue implementing and supporting these efforts. And Bridget, there are some things, and you may have them already, I can share them with you in terms of, I think Asta did a really nice summary of what was in the budget and kind of broke that out to sort of give it more of a quick read. And I can share that for Urban to share that with the group as well. Thank you.
Excellent. Thanks, Benita. And I know Jenny's going to be wrapping up because we're out of time. But I just chatted to. Thanks, everybody. We didn't get to every question, but we will be kind of compiling some sort of Q&A document that we'll send out along with materials and the various things that have come up that you all have requested during the session, resources we have, like what Benita just mentioned. So stay tuned for that. We'll send it to all the registrants. So everyone that was here and everybody that registered for this and couldn't make it.
Well, I would like to just close with our traditional event satisfaction poll. If you could fill that out really quickly. And just to plug a couple of upcoming events. If you were planning to attend an orientation or have someone in your organization attend that tomorrow, that has been postponed, but we do have some yoga and mindfulness workshops coming up soon that we hope all of you will be able to attend. And please look for the links to register on the community page. And I would just like to close by sending our thanks to Sarah and Benita for your time today. And thank you so much to the learning community members who offered to facilitate the breakouts. We will be in touch with a rescheduled date for some smaller group discussions about how you can change your messaging as the PHE winds down. So thank you so much to everyone for your participation, your great questions, and we'll be in touch with more resources soon.
Thanks all. And thanks to our facilitators for being willing to, to facilitate those breakouts and for being flexible when we changed on the fly to a different approach. Really appreciate it. We appreciate
I think that's going to be great because I think we're going to have that additional information and even more questions. So I'm looking forward to that as well.
That's
Thank you
true.
all
We will be
so
able
much.
to, yes, you're right, Benita. We'll be able to kind of supply some things in between that now in that session that might really help those discussions. And so thanks very much. And thanks to our great speakers. This has been very helpful.
Thank you, everyone. Have a great day.
You too. Thank you all. Bye.